Hello, today we'll look at the treatment of unipolar depression and we are dealing with maintenance treatment. So I made another video explaining about initial treatment. That means the patient comes and we detect that this patient have a depression. And then we treat it initially with medications. And now this patient is already treated and this patient should be now treated with a maintenance treatment. That's something else. That is something that is for a longer period of time, not the initial treatment that is done quickly at the spot to decrease this depression so that the patient does not commit suicide. Now, maintenance treatment will be dealing with the patient for a longer time so he stays stable. Because many patients, as we know, will relapse. So let's look at it. How many patients do you think relapse within 1 year after the acute therapy is done? 50%. Just think about this. So you had a patient who was treated properly, and in 1 year he got the depression once again. Therefore, maintenance treatment is so important. So 50% of patients will relapse within 1 year after a successful acute treatment. The definition of relapse being that we have depressive symptoms appearing again after this successful acute initial treatment that we dealt with in this other video. So relapse, recovery goes hand in hand. So we need to think of relapse as something that we prevent by this maintenance treatment. What is the difference between continuation and maintenance treatment? Because these two words sound very similar, but they're actually not the same thing. Continuation means that we have a treatment from 4 months until 1 year after this acute treatment, and maintenance treatment is 1 year and more, so until 3 years. Okay, and then of course there exists also treatment that is sometimes lifelong, but this is very rare. But there exist patients that need treatment for more than 3 years. Continuation. So the patient comes and we will tell this patient that, okay, we will not let you go home without any medication. You will need to take this medication for between 4 months and 1 year. And then we see how the patient manages this. If everything goes fine, usually we can taper it down and then stop this medication. But if not, we need to do a maintenance treatment, which is 1 year to 3 years. Okay, so this is the difference. Continuation is until 1 year, maintenance is 1 to 3 years of therapy. Which patients benefit from a maintenance treatment forever? This is the rare case where we have patients who need treatment forever. Actually, patients who had 3 depressive episodes, 1, 2, 3. He had episodes of depression 3 times in his life already. Or the patient had chronic depression for more than 2 years already. So more than 2 years of chronic depression. Or previous suicidal attempts, because these are patient groups that we really need to take care of. We don't want these patients to die. We don't want any suicide attempt. And other psychiatric diseases. So there exists also patients with a lot of depression plus other psychiatric diseases. And these 4 things have to now be considered when we are dealing with patients for maintenance treatment forever. So those with more than 3 episodes, those that had a chronic depression for more than 2 years, those that already had a suicide attempt, or those who have a lot of other psychiatric diseases. So when is maintenance treatment needed? When we have risk factors for recurrence. So risk factors for this relapse again. After recovery of chronic depression, so more than 2 years, so the maintenance treatment is needed when risk factor for recurrence, or after recovery of a chronic depression, so more than 2 years, or after a suicidal attempt. So this is a kind of similar what I said in the previous slides, the 4 things that we need. These 4 things to say that this patient needs the maintenance treatment forever. Okay, but the difference here is that maintenance treatment is until 3 years, and then these 3 things should be there. And if you want to reevaluate the patient to get the treatment forever, usually we need more than 3 episodes of depression, as we said. That was the difference here. So now let's look. Which are the risk factors for recurrence? The risk factors that we're talking about when we are dealing with maintenance treatment is childhood abuse. Did this patient have a childhood abuse as a child? Early age of onset. Is this patient 18 to 21 years of age? These are all risk factors for getting a severe depression or getting a depression again, and therefore these patients need maintenance treatment. A history of more than 2 depressive episodes. This is a risk factor. We talk about 3 episodes when we're dealing with patients who really need this maintenance treatment forever. Here, it's only enough to have more than 2 depressive episodes. Persistent symptoms like sleep disturbances or suicidal ideation or hopelessness or rumination, which is constant thinking of the same thing, so ruminative thinking. So persistent symptoms of one of these. So we have sleep disturbances, then we have the suicidal ideation, the hopelessness, and constantly thinking about the same thing, rumination. And these are risk factors for recurrence. Anxiety disorders is also a risk factor for recurrence. So we have many patients having depression and anxiety at the same time. Marriage problems or stress at the work, this is also very common risk factors for having a recurrence of depression. So we have marriage problems and stress in your work. Okay, so should continuation treatment always be done after an acute treatment? That's the question now. Should we give this to all patients then to somehow protect everybody? Actually, not in all cases, but in general, we can say yes. So generally, yes, but it is not necessary after we have done a successful medication treatment and psychotherapy, and we have seen that there's really no risk factors that we talked about. I made this list about risk factors and no risk factors. This cognitive behavioral therapy, so the psychotherapy was very good, was very well done, and there's no symptoms anymore at all. No symptoms, the treatment was good. Then we can consider this patient to not get any continuation treatment. We will stop it and we will see if he comes back in 1 year. As we said, 50% of patients will come back with the depression, but the other 50% will not, okay? So should continuation be treatment? No, not in all cases, but usually it's good for most of the people. So which medications are used for continuation and maintenance treatment? The same antidepressants that we had in the initial treatment part. The same dose, the same antidepressants that was successful in treating the patient at the first spot. We don't want to complicate this. So if the patient was very well treated with one type of medication, then we will continue with that. Okay? In the initial part, in the initial treatment, there is the chance to find out which medication is good or not. But when we have already a successful result, then there's no need to switch to another medication. So please give the same medications. And I have listed all the medications in the other presentation, which is called treatment initially. Okay? Look at that video, please. Which is the most studied psychotherapy for continuation and maintenance treatment? Actually, this is cognitive behavioral therapy. That's the most studied one. This does not say that this is the best one. It just means that this is the most studied one. Okay, so cognitive behavioral therapy. So what does sequential treatment mean? Sequential means that we had medications that we used acutely, and then we changed it to a psychotherapy instead. So we had medications and we changed it to a psychotherapy instead. That's a sequential treatment. And that is also possible to do. So we stop the oral tablets that you take. Instead, we continue with psychotherapy. And this is also good as a continuation treatment, because we follow up the patient regularly by a psychiatrist or a psychologist who will then measure who will look at the symptoms, and then he will be able to tell a psychiatrist or a doctor if we need to add the medications again. So it's a very good follow-up strategy. Which are the advantages of psychotherapy compared to medications? The advantages are, of course, that there are no side effects with psychotherapy, in the sense that there's no organic chemical side effects. Of course, psychotherapy can have its own side effects, meaning maybe the psychotherapist is different, is not really in a good relationship with the patient and the patient gets angry. I don't know. But what we are dealing with here is chemical side effects. So there's no side effects of psychotherapy. Not teratogenic. So it is good for a pregnant woman. It is a better compliance, meaning the patients usually do prefer psychotherapy compared to a lot of medications. So the better compliance. Compliance just means that how good is this patient doing the treatment that is given. And usually the compliance of taking medications will drop after a time. So after some weeks, the patient will feel that, no, but why do I need this treatment? So I don't need these medications anymore. Let's stop it. And then they stop the medications and then they come back with the depression again. So it's very important that if you're a patient, please take your medications. If you are considering on stopping your medication, then please go to the doctor and discuss it with the doctor before you stop it. Okay, so don't stop it by yourself. This is a very important thing. With psychotherapy, there's better compliance. There's no need to have any problems with this, because we have a psychotherapist who have a scheduled time, a scheduled appointment. Next week you will come, and then we see that usually the patient comes to this appointment. Improved social functioning, yes, this has been seen also. With psychotherapy, actually, the patient starts to behave better because they are discussing a lot of social things, a lot of social family things that with the psychotherapist, and the psychotherapist can usually give a lot of advice to these patients, and therefore they are actually functioning very good socially. So, which are the advantages? We said no side effects, it's not teratogenic, the compliance is much better, and the social functioning is better also. When is it not advisable to do a sequential treatment? The sequential treatment was that we had the medication and then we switched to psychotherapy. When is it not advisable to do that? By high risk factors for recurrence. We listed the list of which are the risk factors for recurrence. If we have high risk factors for these, then please don't do a sequential treatment. Continue with the oral tablets instead. Okay? How often should follow-up visits take place? In the beginning, we have every 2 weeks, then every month, then every 3 months, then every 6 months, and then we can do it yearly. So it's very convenient. Every 2 weeks, then every month, then every 3 months, 6 months, and yearly. So we're increasing the span of the follow-up visits. Why? Because of time constraints of the doctors? No. It is no use if we see that it's going well. It's no use to do it every 2 weeks if everything is fine. So therefore we can increase it and we can let the patient go. Okay. Name some important questions during the follow-up visit. So which are the questions that I will ask during the follow-up visit? We have symptoms. So which symptoms do this patient have? And as we know, I made a presentation about PHQ-9 questionnaire. This is a very good questionnaire. You have 9 questions. You ask these 9 questions, and then you can see at each follow-up visit how this patient is responding to these 9 questions, and therefore you can standardize the score that the patient has. And then you can do a graph, and you see if the patient is doing better or worse. And this is a very good thing to do. So PHQ-9 questionnaire, please look at that video. Suicidal ideation is very important to ask at all follow-up visits, because if you're not asking it and the patient is killing himself the next day, you can be charged by the lawyers. So please watch out. Suicidal ideation is a very important topic that all doctors need to be able to recognize. Okay? Compliance. You ask about compliance. Do you really take your medication or do you not? And you have to ask it in a way that can catch the information, because many patients will lie. They will straight up lie to you, and therefore it's important to somehow ask the questions in such a manner that you will get a proper answer. And you have to deal with the patients in such a trustworthy way that the patient can trust you. You are not their father. You are not the authority. You are a professional that is helping the patient. You are at the same level as the patient. So every doctor is at the same level as the patient is. And this is a cooperation. It's teamwork. The patient should trust you with his whole heart. And if the patient trusts you with his whole heart, he will tell you everything. Side effects. Side effects is something that we will ask, of course. When you take the medications, do you feel anything? Did you gain a lot of weight? Do you have diarrhea? Do you vomit? And so on. There are many possible side effects of medications, and therefore it's important to ask for these, because we can change the medication if this is bothering the patient. Because what happens if something bothers the patient? He will stop the medication. So if he takes the medication and he gets diarrhea all the time, then he will stop it. He will not use this medication because he thinks that this is annoying. He cannot work anymore because he's going to the toilet every time. And then he says, okay, let's remove this, and I will tell the doctor that I'm taking the medication. This is the compliance, and this is what I'm saying, that you have to ask about compliance, you have to ask about side effects, you have to ask about social functioning. How is it going socially? Is it good? Is it bad? And so on. Talk with the psychotherapist to find a strategy that can help you. Good. Which standardized questionnaire is very good during follow-up visits? I have touched this, PHQ-9. Please use this. It's a very good tool, 9 questions, and you will find out many things about the patient. What does the word tachyphylaxis mean? This is a very, very interesting word, and it is no logic behind this word. One can feel it means that we have a relapse despite continuation or maintenance therapy. This is the meaning of it. So this means that the patient is having this continuation therapy with the same medications as we had with initially, and despite this patient is having a relapse. That is called tachyphylaxis. So tachyphylaxis, why is this important? What should sequentially be done when tachyphylaxis happens? Sequentially means, do you remember what I said? Sequential therapy was that when we switched from medication to psychotherapy. So what should sequentially be done when tachyphylaxis happens? Do we switch the medication, or what do we do now? Medication dose should be optimized. Because why? We have a maintenance treatment and it's not working. The patient is relapsing with his maintenance treatment. So we need to optimize the dose of the medication. That's the first step. Optimize the dose. Depression-specific psychotherapy. We need to involve psychotherapy more and more in this with these patients. So we said we had 2 weeks, then 1 month, then 3 months, then 6 months. Now, let's say we have 6 months. Every 6 months we are dealing with this patient. Now we will change it to 3 months again. We will increase the frequency of the appointments. Okay. Now every 3 months, and if that is not enough, then every month. Increase frequency of psychotherapy sessions. This is what I'm talking about. Increase the sessions. Increase the dose of the medication. We need to step up here. Switching therapy is also an option, meaning maybe this medication does not work. We maybe need to switch the therapy, okay? Switch this therapy to another one which is better and test it out. So if the doctor and patient decides to discontinue the continuation therapy, then how should this be done? So now we want to discontinue the continuation therapy. We taper the medication, meaning we slowly but surely decrease the dose of the medication, and we have frequent follow-up visits monitoring any relapse that the patient can have. Because as we are tapering down the dose, then maybe the relapse will be stronger and stronger, and we need to monitor it. How? PHQ-9 questionnaire, we will see if the symptoms start to increase. And then we will see that the points starts to increase. Good. When should electroconvulsive therapy used as a maintenance therapy? When medications fail many times. Meaning we tried this one, we try to increase the dose, then we try to switch the medication to another one, we try to increase that dose, then we try to switch it to another one, then we try to increase that dose, then we try the combination therapy, we tried one medication with another at the same time, we increased the dose, we optimized it, nothing works. Bam, electroconvulsive therapy. This is the last resort, one can say, and this is really good. Electroconvulsive therapy is working, but we will not do it for all the patients. Why? Because we will start with medications. Electroconvulsive therapy needs an anesthesiologist. It needs specialized clinics that do this. Not all hospitals will do this, and therefore we start with medications first, and we refer these patients to these clinics when we see that we cannot handle it with medications. Is exercise good against depression? Yes, it reduces depressive symptoms very, very well. So please exercise. This has been proven. Many studies have been done. Exercise, healthy diet will all decrease depression. Trust me on this one. The one antidote which does not cost a lot is exercise, and this will be very good against depression. So, quick review. How many patients relapse within 1 year of the acute therapy is done? 50%. 50% relapse. So therefore, this presentation is important. Why? Because we want the patients to be free of symptoms, because depressive symptoms will appear again when we have a relapse. And this is appearing after acute treatment. So relapse definition is after acute treatment. Good. The difference between continuation and maintenance is that continuation between 4 months and 1 year, maintenance between 1 year and 3 years. So 4 months and 1 year for continuation, and maintenance 1 to 3 years. Continuation until 1 year, maintenance 1 to 3 years. I'm telling it many, many times, therefore you will remember it. Which patients benefit from a maintenance treatment? Forever. Those with more than 3 depressive episodes, those with chronic depression for more than 2 years, those with previous suicidal attempts, and with other psychiatric disorders. When is maintenance treatment needed? As we said, this will be almost the same list. Risk factors for recurrence, we have recovery of chronic depression, which was more than 2 years, and after suicidal attempt. Then we need maintenance treatment. The risk factors are childhood abuse, early age of onset, so 18 to 21, history of more than 2 depressive episodes, persistent symptoms like sleep disturbance with suicidal ideation, hopelessness, and rumination. Thinking about the same thing and not getting out of it. You're stuck in your own negative thoughts. Anxiety disorder is also a risk factor. We have marriage problems or stress at the work. The continuation treatment should be done after an acute treatment, generally all the time, but it's not necessary if the patient has no symptoms, there's no risk factors for any recurrence, and this cognitive behavioral therapy or any other psychotherapy in general, if these can be done and it is successful, it is enough, then please do only psychotherapy. You don't need to do any continuation treatment with medication, with tablets. Okay? Which medications are used for continuation maintenance treatment? The same as we did in another presentation that was called treatment initially. That is same dose, same treatment, because if something works already, then please continue with that. Which is the most studied psychotherapy? It's cognitive behavioral psychotherapy. Sequential treatment means that we have medications first that was used accurately, and we change that to psychotherapy. Change medications to psychotherapy. Which are the advantages of psychotherapy compared to medications? There's no side effects. There's not teratogenic, so it meaning it's not harmful for your baby, for a pregnant woman, and it's better compliance, meaning the patient will go to psychotherapists rather than taking medications, and improved social functioning. What is not advisable to do when is it not advisable to do sequential treatment? When we have high risk of this recurrence, the list that we had, child abuse and these things. How often should follow-up visits take place? In the beginning, we said every 2 weeks, then every month, then every 3 months, then every 6 months, and then yearly. The important questions that we ask are symptoms. Which symptoms do you have? The PHQ-9 questionnaire. Then we have suicidal ideation. Then we have compliance. We ask about compliance. We ask about the side effects. We ask about social functioning. Then we have standardized questionnaire, as we said, PHQ-9. Remember this. Look at this video, please. What the word tachyphylaxis mean that we have a relapse despite discontinuation treatment or maintenance treatment. So this patient relapse despite this. The sequential therapy means that tachyphylaxis means that we will now do a dose optimization. So we had this tachyphylaxis, that was the relapse. We'll do optimization of the medication, increase the dose. We will give a lot of psychotherapy. We'll increase the frequency of it, and we will switch maybe the treatment to another medication. If the doctor and the patient decides to discontinue the continuation therapy, then what do? We will taper the medication down dose, and then we will increase the follow-up visits, and we will monitor. It means we will ask a lot about questions about symptoms, and then we will see if the patient had a relapse or not. When should electroconvulsive therapy be used? When medications fail many times, as we said, and this is the last resort. Exercise is very good against depression, so please exercise a lot, and let's treat this depression for life, okay? And consider always continuation treatment, maintenance treatment, because many patients need it. Unfortunately, as we said, 50% of patients will relapse within 1 year. So take your medications, have a high compliance, and exercise, and have a nice day. Thank you very much for listening.